Okay, I think I need someone has to give me the rights to upload my presentation. Or
it's done, I think.
Exactly. Now I've got it now. I've got it now. 1 second, please. Okay. So I assume you are hearing me, isn't it?
Yes, we can hear you.
Okay. So if there is anything, you just prompt. So good afternoon for you. Good evening for me. I am Xavier Bosch-Capblanch, and I am working at the Swiss Tropical and Public Health Institute. This is Vilnius, where I am talking from. So it's in the evening actually now. I would like to share with you some work that we have been doing on supervision. And actually all this started while I was a civil servant for the government of Ghana, with working in a couple of hospitals in Ghana where I was actually supervising, and also I was supervised. So I learned there firsthand all the penible things that I have been reading later on in the research articles and other reports about supervision. And we did actually, that was what, let's say, what triggered my interest in this topic. And then later on, we were working on a literature review, trying to scope supervision to understand what people was understanding about supervision, their components, etc. And actually, this was a preparation for a Cochrane review on the effects of supervision on quality of care. And more recently, by chance, we have been able to summarize the evidence on several issues, but including supervision in relation to integrated community case management of childhood illnesses. So I would like to share with you some of the issues in these 3 pieces of work. So from research evidence, from studies, actually all sorts of studies, observational studies, experimental studies, also guidelines, all sorts of documents, we summarize the different components of supervision. So supervision can be clinical when you are actually supporting clinicians in improving their clinical practice, but most commonly, and that's the concept of supervision that we are dealing with, is managerial in terms of all the functions that the district health officer or the head of a health facility needs to comply with in order to manage the health facility and to deliver care. Usually supervision embraces primary health care as a whole, but there are many examples as well of supervision that focus on specific programs or areas, and actually reproductive health is one of the outstanding areas, and you can have many others as well, or even specific programs, supervision of specific programs. What supervision is about, in many occasions, it has to do with information. So, all that has to do with the reporting to the health management information system, reporting the volume of activity, all this flow of information from the periphery to the headquarters. And other areas of supervision, less frequently, is about resource management, problem solving, etc. Actually, supervision, we have seen examples, and the most common way of being implemented is with visits from the headquarters to the periphery. So the district medical officer will travel to the health facilities in the periphery, but there are also ways of supervising by which meetings at the headquarters are organized, and then people is getting to the headquarters. You have all sorts of supervisors. We have not been able to find a lot of description on the gender mix of supervisors in several settings, and very often supervision is actually preceded by training with many different schedules and intensities of training. And the frequency also varies greatly, and we somehow estimated the median from the studies that we were collecting, and it was like 2 times, once every 2 months. We looked also, because this was reported about barriers to supervision, and there were examples of, obviously, structural violence, armed conflict, but probably the most frequent barrier had to do with logistics, transport, fuel, money, and there are all sorts of barriers that you are very familiar with, I'm sure. From the programmatic reports that we examined, these were 28 from sub-Saharan African programs and one from Myanmar. And again, we found basically the very similar components as we have seen in the other body of evidence, except that maybe here we were basically looking at supervision in the context of integrated community case management. So it was very program-based supervision, but again, the supervision areas were very similar. There was a great variety of supervisors. Also in their profiles, you could have administrators, public health specialists, even environmental health officers doing supervision. And you could also have inspectors, health district officers, and even in this type of programs, you could have more senior community health workers supervising more junior community health workers. And again, great variety in the ratios of supervisors, supervisees, and in the frequency of supervisions. Here, from these documents, from the programmatic review, although we were not expected to measure effects as such or to report effects as such because of methodological constraints, but actually there seemed to be some evidence that quality changes seem more remarkable in large programs where you had several components like training, supervision, supplies, incentives, and this type of programs, these bigger programs, seem to result in more examples of indicators of outcomes that would show improvements. In the Cochrane review, we, as you can imagine, basically we reviewed many, actually hundreds of abstracts, but finally we included nine studies, 5 cluster randomized control trials, and 4 control before and after. And this table is just to exemplify the different types of comparisons that we were faced with. So basically there is no repetition of comparison. You would have supervision and monitoring with feedback compared with no supervision. That was one of the 9 studies, and you would have at the end the 9th study actually comparing quarterly supervision as being the intervention, so a less intensive supervision against monthly supervision. So very, very difficult to, impossible actually to summarize 9 different comparisons. The quality of evidence, I didn't even mention this in the previous previous slides, but the quality of evidence of these studies included in the Cochrane review, it was very, very, very poor. And actually, basically, you would expect a lot of green, and here it's very difficult to find. You have 1 or 2 criteria where more than half of the studies have low risk of bias. So all this evidence actually has a high risk of bias. And what did we find? Well, we find examples of outcomes that were improving, like performance of community health agents, some scores, some quality scores, like certain midwife scores. And there were some examples of outcomes which actually did not change or didn't show any improvement. So actually, supervision, as we have seen from different sources of evidence, including programmatic evidence, supervision is a very complex intervention. It's very difficult and very complex just to get someone from the headquarters to move towards the periphery of the system to a health facility and do something there that is meant to improve a health outcome. This thing it sounds like brief and simple, but this thing is very complex. Not only this, but also supervision is accompanied with other interventions. It hardly goes alone. Many times you will have guidelines, you will have other tools, you will have supplies, incentives that go along with supervision, which are not actually supervision itself. And then, besides that, supervision is implemented in many different ways. You can have visits, you can have meetings, you can have it monthly, you can have it in many different intensities. So there is no single, when we are talking about supervision, there is not a single, not even a preferred way to implement supervision. You have thousands of supervisions or types of supervisions. It's very difficult to have an archetype of what is supervision. And if you look at the side of the outcomes, well, you have multiple quality of care outcomes. You have, depending on the dimensions of quality that you want to measure, depending on the perspectives of quality. And so it's very easy to find examples of everything or anything. So when we talk about doing research in the sense to assess what are the effects of supervision, well, we have many different interventions under the name of supervision, and we have many different outcomes under the names of quality of care outcomes. So what is the causal pathway? Well, I may disappoint you, but I don't have an answer here. And we are now updating, or we are planning to update the Cochrane supervision, the Cochrane review, and we are struggling with this. So basically because we don't find, and this was a bit in the line of what Mike English was saying, but we don't have a health systems framework, an analytical framework that is not just a description of components. We know that there is governance, we know there are financial resources, that's fine, financing, whatever, that's fine. But this does not give us any analytical power, any capacity to predict what is going to happen when we submit the health system under different types of stresses. And if we don't have this pathway, I don't see how can we understand what is supervision and try to measure in a meaningful way its effects. So from our perspective, the priority number one is certainly to develop an analytical framework. I mean, if there is no framework, there is no knowledge. We will end up doing more research, if that's what we have to do, which I doubt, but we will end up having much more research about many outcomes, many different outcomes, many of them actually relevant, and assessing interventions which we actually don't understand completely. We also have to figure out what do we need to evaluate, because, I mean, supervision is a link between the headquarters and the periphery. I don't think no one is thinking that we have to actually conceive that the periphery of the system has no contact with the center. So certainly that's not the point of supervision. So there is something else that we have to test. And then if we want to do this, we need to pin down the methods. I don't think that the complexity is not an excuse for poor quality research, and the examples of poor quality research are massive. And also we should also pin down the outcomes, because we cannot just say anything about it and take it as a good sign. That's all. Thank you very much for your attention.
Thank you very much, Xavier, for your presentation and for joining us in your evening time from Basel.